Can you see my slides, sir?
Yes, ma'am.
Yeah. So I'll be talking on the post-immunotherapy new onset diabetes, that is otherwise we call it as PINOD. So this is a new onset diabetes following immunotherapy done with certain solid tumors. So basically this entity has been first time coined and enlightened by Markand et al. So the diabetes that was first time developed following the PD1 and the PDL1 and the CTL4 inhibitors. So I'll start with two cases. So I have the case one. Here is a 29-year-old male who was diagnosed with non-small cell carcinoma of the lungs, and initial staging was done with MRI, which revealed a very advanced disease with bilateral lung involvement, nodal spread, and metastatic bone disease. And in the background, he was a smoker. Then he was initially treated with the normal conventional treatment, that is carboplatin and pemetrexed and docetaxel. But 1 year later, because of the disease progression, with asymptomatic brain metastasis, the treatment was switched over to nivolumab 3 mg per kg, which was initiated. And then after 10 months of the treatment with nivolumab, the patient was hospitalized because of generalized weakness, polyuria, polydipsia, and significant weight loss. And at the time of admission, his blood sugar was 671, and there was also evidences of ketoacidosis. There was no prior personal and family history of diabetes mellitus, which was noted, and he had no fever and symptoms suggestive of any kind of infection, and CCT abdomen was initially clinically very insignificant, and his A1C was 6.8% and C-peptide level was low, and all his other parameters related to pancreatic enzymes, anti-GAD antibody, TSS level, anti-IgA, they were also negative. And then he was treated with insulin, IV fluids, and other conservative treatment that we normally follow for this patient. It was done. Then the second case was, here is a 69-year-old. The first one is a younger patient, and the second was again 69-year-old male, which had a background history of type 2 diabetes mellitus for 4 years and had been managed with the required oral anti-diabetic drugs, and his A1C was maintained at about 5.9 to 7.3%. And recently he was diagnosed as a case of, again, non-small cell carcinoma stage 4, who presented with nausea, vomiting, polyuria, polydipsia, and weakness of only 4 days duration. And he had been undergoing chemotherapy with carboplatin, pemetrexed, and pembrolizumab, and had completed his 4th cycle 20 days prior to this presentation. And the workup for potential precipitating factors, they were all done, and it was all of them, the results after exclusion of the infectious and the common metabolic etiology, it was thought that the patient treatment with pembrolizumab may have led to the new onset, that is immunocheckpoint inhibitor-induced type 1 diabetes presenting with diabetic ketoacidosis in the background of a type 2 diabetes mellitus. And subsequently, when C-peptide was done, it was found to be undetectable. Anti-GAD antibodies, they were all elevated, both which were consistent with the diagnosis of type 1 diabetes mellitus. That means there are two kinds of diabetes. One patient already had type 2 diabetes mellitus. Then later on it was diagnosed as having type 1 diabetes, maybe insulin dependent diabetes. Then at the same time, his pembrolizumab was held for 1 cycle. Then thereafter it was resumed. So here we have the background of these two cases. So I will just discuss about this entity. This is a post-immunotherapy new onset diabetes post-immunotherapy. So basically there are immunocheckpoint inhibitors, which are also called as the PD1, inhibitors, that is programmed death cell 1, and the PDL1 inhibitors. So in the name of nivolumab, pembrolizumab, and durvalumab, as well as CTLA4 inhibitor also. They are all group of drugs which are used for the pulmonary and cutaneous malignancies, especially the solitary malignancies, the solid tumors. In the first case of such kind of diabetes, they are thought that this could be just type 1 diabetes mellitus or just the idiopathic variety of the type 1 diabetes mellitus. And first time it was reported in the year 2015 with the use of the pembrolizumab. And subsequently, multiple case reports of such kind of diabetes, they started emerging, occurring in 1% of the case treated with such kind of drugs. And largest case series, they comprised of about 30 patients, highlights the scarcity of the data of such kind of drugs with type 1 diabetes mellitus. So diabetes following use of these drugs, they occur after a time span of about 2 to 13 months. That was reported by Markand et al. And the cell-mediated structural functional beta cell destruction with or without alpha cell involvement with exocrine pancreatic dysfunction and polycloral disease. And this phenotype was also first time it was described by the Markand et al. So this PD1 and PDL1 induced diabetes was immune in nature, but it was not human immune dysfunction that was basically characterized in the autoimmune type 1 diabetes mellitus. So rather it is a cell-mediated immune activation by the immunocheckpoint inhibitors, causing immune-mediated reaction leading to a wide spectrum of immunoreactive adverse events. And the beta cell destruction because of these drugs, they can cause ileitis and subsequent development of type 1 diabetes mellitus. Maybe later on it can also cause type 2, it can also occur in the background of the type 2 diabetes mellitus, and such kind of diabetes normally has been seen that they are very severe. And here is the mechanism of action of the immune checkpoint inhibitors. This is the antigen presenting cell. This is the inhibited T cells, and this is the cancer cell proliferation when any kind of cancer occurs. The immune response is basically regulated by the balance between an inhibitor and stimulatory signals. And these PD1 proteins, they're normally expressed over the T cells, L cells, and the peripheral tissues, and also NK cells. And when it binds to its ligands, that is PD1 and PDL2, it inhibits the T cell proliferation. So that is how the cancer doesn't occur. And if when you are using this ICPR immunocheckpoint inhibitors, they are basically regulatory molecules that modulate the T cell stimulation or the inhibition, thereby preventing the inadequate response and promoting the cell tolerance. And one of these pathways is the PD1 pathway. The PD1 pathway is exploited in the tumor microenvironment and promotes the tumor immunoevasion. And this immunocheckpoint inhibitors in the form nivolumab and these drugs, so they bind to the PD1 receptor, inhibiting the protein's interaction with its ligand, augmenting the local immunity, killing the cancer cells. So this is the mechanism of action of the immunocheckpoint inhibitors. So such kind of patient, they normally present with diabetic ketoacidosis. They are having an undetectable C-peptide, having severe symptoms including significant weight loss. They present with decay and follow a rapid fulminant course, and this needs awareness among all endocrinologists, diabetologists, even the oncologists also. The author reports this rapidly increasing series of such kind of cases as a diabetic storm ahead, or it was named as a fulminant diabetes. Gender, age, BMI, and the past history and the metabolic status not show any unique characteristic along with this diabetes. And their effect has also been noted on various endocrine systems. It's not only the ileitis that causes diabetes, there are other endocrine systems also, they are also affected in the form of autoimmune thyroiditis and also hypophysitis. So oncologists especially, they need to be very alert about the endocrine adverse events related to such kind of drugs while using them. Next comes how do you, that is the differential diagnosis of such kind of situation. One is definitely type 1 diabetes mellitus, which is commonly attributed to the increased genetic risk and the presence of anti-GAD antibodies and anti-islets and antibodies, insulin antibodies or insulin associated to that and to antibodies. Accordingly, in cases of type 1 diabetes that is precipitated by the immunotherapy, several patients were also human lymphocyte antigen genotypes, and approximately 50% they were found to be positive for relevant antibodies, that is GAD antibodies being predominant among all the antibodies. Serum lipase, serum amylase, elastases, they also have been investigated as the possible markers indicative of pancreatic inflammation. And how do you approach such kind of patients? So a serial blood glucose monitoring of the patient should be done and being treated with, should be done in those patients who are being treated with immunocheckpoint inhibitors on a regular basis and on a regular interval, which is very crucial when you want to recognize such kind of type 1 diabetes mellitus. But there is no biomarker which can predict the diagnosis, and in known type 2 diabetes mellitus, this immunocheckpoint inhibitor induced type 1 diabetes mellitus may be masked and overlooked as a manifestation of uncontrolled type 2 diabetes mellitus, highlighting the importance of a low threshold for the suspicion and initiation of the further workup. And look for the rapidly deteriorating fulminator course requiring the IV insulin and IV fluids, whatever we do treat in treating the type 1 diabetes mellitus. So while there is a suggestion from the right et al. That while treating this patient with such kind of drugs, we need to obtain one GAD antibody levels in patient with type 2 diabetes mellitus, especially prior to initiating this treatment with immunocheckpoint inhibitors, so that we can identify those who might be at risk for developing this immunomediated diabetes mellitus. Also, we can look for the family history of autoimmune endocrinopathy, vitiligo, skin rashes, which could be a few factors that could predispose them to this immune-mediated diabetes mellitus. And such patients with immunocheckpoint inhibitor-induced type 1 diabetes mellitus, which has gone unrecognized, and they may develop diabetic ketoacidosis, which is potentially very fatal if not recognized and treated in a timely manner. The NCCN recommends holding the immunocheckpoint inhibitor therapy among patients who present with for the first time with RBS more than 250 milligram per DL, or they present with diabetic ketoacidosis, as was done in our case when we also stopped the treatment. How do you manage such kind of patients? So early detection is very important so that we can institute the treatment very early. This is the key to the therapy, and the OAD which our patient was taking prior to the presentation, that was the type 2 diabetes mellitus, were held temporarily and was started on insulin, degludec and aspart, the basal bolus regimen. However, due to the history of type 2 diabetes mellitus and difficulty in achieving the adequate glycemic control despite being on a tailored insulin regimen for 15 months, metformin was also reintroduced, and later on the patient had a good glycemic control. Hence, immunocheckpoint induced type 1 diabetes mellitus among patients with history of type 2 diabetes mellitus, they present a new entity. They require an evolved treatment approach where a baseline insulin regimen may be supplemented with the oral anti-diabetic drugs. So this is how treat, and if diabetic ketoacidosis is present or anticipated, start insulin, even you can start it beforehand. And the insulin deficiency in such kind of cases, they warrant treatment with a tailored insulin regimen, as was done in our patient, and treatment approach is similar to any kind of diabetic ketoacidosis. And among those patients with history of type 2 diabetes mellitus, the treatment of these drugs in type 1 diabetes mellitus may constitute a combination of oral anti-diabetic agents to tackle the presence of insulin resistance along with the customized insulin regimen to address the acquired insulin deficiency. Next comes the what is the course of this disease. The glucose control is universally achieved with insulin, and several immunoreactive adverse events, they have been reported to spontaneously resolve with the discontinuation of the immunotherapy, but might not prove true for the majority of these endocrinopathies. Further, large-scale studies concerning the reversibility of immunocheckpoint inhibitor-induced endocrinopathy are also urgently needed. Diabetes mellitus, the result in complete beta cell destruction and is therefore not reversible, and long-term exogenous insulin dependency is inevitable, and only a single case report which was mentioned reversal of the insulin dependence, but that patient had documented residual beta cell function also. So there are certain few series I'll discuss. This is the first series that was described by the Markand et al., a series of the PINOD. So there are 5 men and 1 woman. The median age was 67, and 3 subjects are treated with nivolumab, 2 with pembrolizumab, and 1 with durvalumab. And median time to diabetes onset after the therapy was 4 months. The range was 2 to 13 months, and 4 patients they presented with pulmonary diabetes. None of these had type 1 diabetes mellitus related antibodies, and none of them had type 1 diabetes or pulmonary diabetes, very high risk HLA class 2 profiles. And the bihormonal endocrine and exocrine pancreatic failure previously reported for 1 fulminant diabetes patient was not found in other fulminant diabetes subjects, but glucagon response was blunted in another fulminant diabetes patient. And the pancreas volume was decreased at diabetes onset in this 2 fulminant diabetes patient, and all patients they presented a subsequent decrease of the pancreas volume during the follow-up. So this is one series, and the second series This is the incidence of the endocrine dysfunction following the use of different immune checkpoint inhibitor regimens. This is a systematic review and the meta-analysis. So 38 randomized clinical trials, they evaluated the usage of such drugs for the treatment of advanced solid tumors were identified, resulting in total of 7,550 patients who were eligible for the meta-analysis. Incidence of hypothyroidism was highest among these patients receiving the combination therapy, and the patient on the combination regimen were significantly more likely to experience hypothyroidism and hyperthyroidism than patients on the ipilimumab only. Compared with the patient on the ipilimumab, those on the PD1 inhibitors, they had higher risk of developing hypothyroidism, and risk of hyperthyroidism but not hypothyroidism was significantly greater among patients in the PD1 inhibitor than with the PD-L1 inhibitors. And why patients who receive the PD1 inhibitors, they are significantly less likely to experience the hypophysitis than those receiving ipilimumab. And for primary adrenal insufficiency and insulin deficient diabetes, no statistically inferences were made due to smaller number of the patients. And if not promptly recognized, definitely this endocrine dysfunction can be very life-threatening. So you have to recognize such situations. A new insight in the endocrine-related adverse events associated with the immune checkpoint blockade. So anti-cancer immunotherapy in the form of this immunocheckpoint inhibition is a paradigm shift that has transformed the care of patients with all the solid tumors. And the most frequent endocrine-related adverse events associated with anti-PD1 monoclonal antibody treatment are thyroid dysfunction, whereas hypophysitis is also most linked to the CTL4 in treatment. Type 1 diabetes mellitus, adrenalitis are rare such kind of reactions. This is the endocrine toxicity and outcomes in patients with metastatic malignancy treated with immunocheckpoint inhibitors. Here is a cohort of 551 patients with a median time of diagnosis was 9 weeks. Melanoma was associated with the highest risk of such kind of reaction, and ipilimumab appeared to have the highest percent of such kind of reactions, having a highest risk of pituitary insufficiency and irreversible forms of adverse reactions. So I think now I should conclude this topic. So this entity, that is the PINOD, is unrecognized and unexplored presentation, and it is a very new entity, now needs attention of all of us. And given the rapid course of this disease development, it is suggested that glucose levels be regularly monitored among those solid tumors on treatments with the immunocheckpoint inhibitors, especially the PD1 inhibitor, PD-L1 inhibitor, and CTLA4 inhibitors. The exact pathophysiologic mechanism and the predictive biomarkers that have not yet been established. However, it is of immune nature, and the result is permanent insulin dependence, and corticosteroids are not recommended, although it is immune in nature. So clinicians involved in the treatment of cancer patients, those who are immunocheckpoint inhibitors, should be very mindful and maintain a high clinical index of entity. Patients with pre-existing diabetes mellitus, type 1 diabetes mellitus should be kept in mind and can be treated with an insulin regimen and also supplemented with metformin just to counter the presence of the insulin resistance which was present previously. And in that way, you can achieve a better glycemic control than just using the basal bolus insulin regimen. Further large-scale studies, they are needed to characterize the management of immunocheckpoint inhibitor-induced type 1 diabetes mellitus among those patients with pre-existing type 2 diabetes mellitus. I think I finished, and thank you for your kind attention. So I would love to answer your